Good morning. Like everyone else you've heard from, I am thrilled to be here. I am 30 weeks pregnant and off a red-eye flight last night, so it is really nice to just feel like I've arrived, and this really feels in many ways like the intellectual community that raised me, and so it's fun. I've never gotten to be at a SIREN meeting. I've never gotten to be at any meeting where I feel like I have this many people who I've been sort of a fellow traveler with for now 10 plus years. And so this talk I get to do this morning is really especially exciting for me. Laura was kind enough to give me the opportunity to kind of look back, trace the kind of arguments that led us to a place where we have, or have had recently, so much policy enthusiasm around health-related social needs, but also try and kind of stare some of the critiques of this work in the face and ask ourselves, I think a question that we all wonder sometimes, which is, are we doing the right thing? Like, is this really our job? Or should this be the work of some other person, some other sector, some other organization? I have a funky background in that I'm partly a researcher, but I trained as a staff chaplain at Mass General, and that's always given me sort of an inclination to ask questions that other people tend to say, like, let's turf that for another day. I had to leave a job at one point because someone said, like, you've just kind of become a meeting stopper. And so this is my opportunity to kind of be a meeting stopper in a very intentional way. With that comment, I would just say this is not a talk about evidence. There's going to be tons of talks about evidence. You all are evidence experts. And so I just wanted to flag from the outset what it is and what it isn't. I'm sort of assuming the evidence is what it is and asking, with that evidence, what do we do? What kind of action do we take? So with that, I'm going to try and get going. Title is, Whose Job Is It Anyway? Goal here is to take some time to really explore the question, are we doing the right thing? And the way I thought we would do that is first look back at some of the literature starting, 2011, let's say, over the past 10 years, both that has buoyed this movement and that has, I think, more recently come as a critical voice to say, like, whoa, we're out in front of our skis here. Many of you all in the audience have been part of creating that literature. I'm looking at Stuart Butler right here. You'll see your face soon, Stuart. And so just know we have collectively created it, and now we get a chance to collectively look back. Then I'm going to ask for help because, 30 weeks pregnant, I have no voice. I'm going to call up two of my friends, Eric and Diogo, to do a little, dramaturgy. To call it a skit would be to underplay it. No. And ask you all if it feels relatable, and then we'll kind of use that as an artifact to unpack the rest of the talk about hidden assumptions that I think are at play when people tend to have vehement disagreements about whether or not healthcare organizations should be doing health-related social needs work. Then I'm going to try and offer with my kind of more managerial hat on, like, okay, so what do we do, Lauren? Like, the ethics talks suck because they always just tell you, like, life's really hard. And so I'm going to try and avoid just literally sending you out with that and offer a little bit of a managerial insight about how I would approach this if I were in the hot seat, which I'm not. And then just sort of a mini case. And we've got about 40 minutes, so we're going to probably move pretty quickly here. So looking back at, like, how did we get here? And other people would surely predate this, but I kind of went back to this report from RWJ in 2011, which was this Healthcare's Blind Side report. And it was one of the first real pieces of evidence that, in my mind, set off this sort of wave of enthusiasm, research, and ultimately policy attention. And it was making a set of empirical claims, right, that 4 out of 5 physicians say patients' social needs are as important as their healthcare needs, and that proportion obviously went up for physicians who spent the majority of their time serving low-income patients and communities. And so it was on the heels of this kind of research that people started to say, well, if social needs are as important as healthcare, what are we as a healthcare community, a set of healthcare delivery organizations doing about those needs? And so you can start to see how like a little toe started to get dipped in, and we started to say, well, yeah, maybe we should be doing something about those needs. Then, not because I want to be solipsistic, but because I wanted to recognize my own role in this. You know, Betsy and I think, had some role in writing this book in 2013 that was about the role of social service spending at the national level, at the state level. And then we did sort of gently walk in to say, like, maybe there's also a role for healthcare delivery organizations to do some social service spending or social service engagement themselves. So I couldn't bring myself to go and actually open this book again, but I went on Google Books this morning for you all, and I reread some of what we wrote. And, you know, I picked out this quote where we said, in some ways, the US does not have a comprehensive social service sector, but it does boast an expansive emergency medical system, leaving medical facilities to become a de facto catch-all for the care of vulnerable populations, however inadequate that may be. And so you can see what we're doing here argumentatively is sort of to say, like, look, this stuff is already coming to the healthcare sector. Healthcare is already having to pony up, usually in the form of medical resources to meet social needs. And you can see how we then just kind of, we were not explicit, but we were very much implicitly saying, wouldn't it be smarter for healthcare to more explicitly address social needs with some kind of social care, rather than doing this kind of mismatch of medical care for social needs? Stuart Butler, who many of you will know, I could have chosen one of 25 of his incredible pieces on this issue. I just spotlighted this one about, can hospitals help create healthy neighborhoods? And you can see here, I would emphasize, having gone back through this literature, I think the people who have put pen to paper on this have mostly been very responsible in being careful about the suggestions that we are making. So here, Stuart is characteristically careful. Hospitals are usually seen as the last resort in their communities, the place you go when other things fail. Yet they have enormous potential to be partners in improving the general health of the community. Unfortunately, there are obstacles to them playing this role. Those need to be fixed. But he's saying, look, there's potential, and we need to realize that potential. It is not a full-throated, like, every hospital should be doing new housing creation and create a whole food pantry on site and be paying everyone's electric and utility bills. It's more judicious than that. And I was actually quite relieved when I went back and reread this stuff, because sometimes when we get to the critiques, I think the critiques are more full-throated than the initial sort of proposals and endorsements of the ideas were. And really, when I went back, I was sort of like, good on us for being humble and circumspect in how we started to sort of build the case for healthcare engagement around health-related social needs. This is Sonny Magnin, kind of similarly, and I'll just read the yellow part here, but this is 2017, so you can see us marching forward. With the failure of our current healthcare system to deliver better health and well-being at an affordable cost, exploring opportunities in other determinants of health seems wise, if not imperative. So this is like maybe slightly more energy than there's just potential, that it seems wise for healthcare to be addressing some things that are perhaps non-medical in nature. And then, you know, I had a fun trip down memory lane on the SIREN website. This is the original issue brief that kind of launched 1,000 ships from Laura and Caroline and Nancy Adler, I believe. And here, SIREN is characteristically relying on the need to build an evidence base to explore the medical care sector's interest and capability to address patients' social and economic needs. So again, at the bottom, the yellow part, talking about healthcare organizations, they may be able to contribute to solutions both for individual patients and for communities. So that's sort of an arc of how we've built this case, that healthcare should be doing research, maybe even more than research. I would say this is more us than SIREN, but actually getting out there and engaging and partnering, doing some social service delivery themselves. In response, there's been critique, and I have been on both sides of this debate. So this is me in 2018 saying, like, there's definitely reason to be cautious about how we wade into health-related social need activities. And in this piece in Hastings Center report, I said I offered 2 types of cautions about continuing down this pragmatic path. The first relates to how healthcare entities value social services that may be beneficial to health. I'll say more about it in a minute. And then the second, which is really a set of cautions, relates to how the healthcare sector's position as a potential buyer of social services may work in practice. And here I was especially concerned about what having healthcare organizations as buyers of social services would do to an already pretty fragile and precarious social service network. To call it a system is even more backwards, I think, than calling our healthcare system a system. It's not a system. It's like a field of many flowers blooming. And then this is the one that came most recently and I think caught a lot of attention for good reason. 2 very smart people who are at my institution, Tom Diano and Sherry Gleed, wrote, I think, a fairly forceful piece, with terms like, or sentences like, they do a lead-in kind of referencing what I just walked you through. We disagree. Health systems and hospitals should tread warily into the provision of social services, and policymakers should not encourage this approach. That's forceful. It has real risks. Social determinants of health should be addressed by the social service organizations and governments that specialize in this work. So in summary, I see it as sort of the debate has 2 sides, roughly speaking. Those that feel that healthcare should engage, where engage is encompassing a lot of stuff. Research, partnering, financing, direct delivery, and those that sort of have a healthcare should stay in its own lane view. And on the healthcare should engage side, there's a lot of reliance on data and evidence like that RWJF sort of report saying, look, this non-medical stuff influences health. We call ourselves a health system. Or in our mission statement, we say we're in it for the health of our patients and communities. Who are we to sort of walk away from the determinants most powerful in influencing health to just say like, oh, no, that's too hard. We don't do that. Or we don't have historical expertise. Those who feel we should engage often sort of rely on the idea that healthcare really does, in many cases, have the trust and the kind of perceived legitimacy of communities. And when we look at our friends in social services, sometimes they do, sometimes they don't, but I think some healthcare providers feel like it's a good look for us to get in the game because when we show up, we bring additional kind of political clout to issues, and that's a valuable thing. Last, I would just say, and I remember Betsy and I making this explicit in the book, healthcare is really good at responding to incentives. Healthcare organizations can learn just about anything if you put money in the right order. Like, oh, we don't know how to do safe surgery checklists. Incentive. Safe surgery checklist is what we always do. And so when people kind of do like, it's not our expertise, I'm not sure, I'm like, lots of stuff weren't your expertise 5, 10, 20 years ago, and you got there. So why are we cleaving this off to be a kind of expertise that would just be like utterly unimaginable for you to acquire? On the healthcare should stay in its own lane side, one of the big concerns is an opportunity cost concern. Like if money goes into healthcare sector or into healthcare delivery organizations, that's money that could be better, more efficiently, more effectively spent somewhere else. Maybe directly in a social service budget from a state or from the federal government, or maybe even just kind of coming through healthcare in a circuitous way and then getting kind of contracted or partnered out to community-based organizations. The expertise argument, the efficiency argument, people rightly say everything healthcare does is expensive. We think something like 25 cents on the dollar in healthcare is administrative burden or waste. What are we doing trying to add to the scope of work that healthcare organizations do when we know that that's the kind of fat that they run in a system? And there's a really important democracy concern here, which is to say that if we really lean too heavily on healthcare organizations and we cede the territory to the arguments on the left, well, they got legitimacy, they got trust, and they'll learn it, Most of our healthcare delivery organizations in this country are private organizations in some sense or another. They're private nonprofits, they're private for-profits. We obviously have a public sector, but it's small in comparison. And so there's a question like, who elected these guys to choose whether we should do housing or food or utility assistance? To say nothing of like the tremendous nuance in each of those categories. Or to say nothing of, even if we all agree we need more affordable housing in Boston, there's many communities within Boston that could make a legitimate claim about needing affordable housing. And do we really want, as much as I love them, the leaders of Mass General Brigham, picking winners in whether that affordable housing should go in Dorchester or Jamaica Plain? That's a democracy concern. It's saying like, where is the representativeness in this process? I go to the voting booth, praise be, every November, and I cast my vote. And I do so because I want to use the judgment of the people I vote for to make decisions like this, particularly allocative decisions. And I didn't do that with either the senior executives or the board of my local healthcare delivery system. So like, who the hell elected these people? Nobody. And then the last one is this valuation issue. This is the classic back and forth between the ROI that a healthcare system may perceive for any given HRSN and the kind of social ROI, or the more global return on investment that may be begotten from investment in something like pre-K, universal pre-K. A healthcare system will see some portion of that return on investment as pertinent to their book of business. And because we all typically are doing the research, at least that lands indexed on PubMed, we report the ROI as, $1.27 for every dollar invested. But that $1.27 for every dollar invested does not take into account the value of decreased truancy among fifth graders, decreased crime in a community, because it doesn't directly hit our book of business in healthcare, or it's just too far downstream. It just is outside the window of analysis. And so the idea that we put too much stock in the ROI that we very capable researchers assign to any social intervention is an additional concern. So I've just walked you through kind of the literature and how I see and read what others have written, and I did look back at what I had written too. And as I said, the pro argument, I think, was largely judicious and careful. The sort of critique has been a little more forceful, perhaps because policy in some cases has gotten out even in front of us. Medicaid policies in particular, state waivers. But, I still have the luxury to make a slide that looks like this and say like, man, it's tough, huh? And health systems and clinics just don't have the luxury of equivocation. They have to make decisions, like binary decisions, 1 million binary decisions. Are we going to engage at all? Yes or no? Are we engage on this domain? Yes or no? Are we going to do this or are we going to do the other thing? And that's why I just can't help not make this point. People often look at me as someone who has a degree from a business school and is interested in ethics and think like, whoa, that's so weird. Ethics and management? Wow. But to me, they're like deeply, deeply linked, because this whole debate makes clear how managerial decisions are unavoidably normative in character. To make a choice about whether to engage or not, that binary choice, means that you have to stare this kind of slide in the face and make a judgment call. And in making a judgment call, you're doing ethics. You're normatively saying, I think we should go with the right side or we should go with the left side. And so I just like to point this out, that ethics is not some like divorced, abstract, purely philosophical concept, but it is sort of what we are all doing every day, particularly those of us who are in operational roles, making commitments of dollars and deciding whether or not to throw the resources of an organization behind a given cause or not. So, with that in the backdrop, I'm going to call up the SIREN family players. Eric and Diogo, will you join me? And you'll give my voice a rest. And what I have asked them to do is sort of just read a little bit of what I imagine is the debate going on among kind of operationally inclined people in a clinic or in a health system. And let me just set the stage for you. It was hard to talk Eric into this, you can tell. In a hospital conference room, a community benefits team presents a new plan for more strategic investing in the local community to senior leadership, including Dr. David Abrams, Chief of Surgery, and Dr. Jennifer Jackson, the Chief of Medicine. The new plan has several pillars, each of which outlines institutional efforts to address a health-related social need. Over a coffee break, the following exchange ensues. And scene.
I am growing fairly weary of all the calls for hospitals generally, and our institution in particular, to be all things to all people. Food banks, housing investors, job placement services. I mean, that's just not what we do. At what point do we have to stand up and say, we're a medical institution. Role boundaries are important and must be respected?
Well, I would agree, except we say in our website and everywhere else that our goal is promoting health. In that case, this stuff is squarely in our lane. Besides, we're doctors. It's pretty antithetical to turn our back to the local need.
Clearly, you have drunk the Kool-Aid.
Eye roll.
Respectfully, if your kind has its way, we would become a full social service agency, and maybe a political lobbying organization to boot. It's an old adage, but there is merit to this. No margin, no mission. It's more important that we are here to do what we do best than to not be here at all because we are financially irresponsible.
My kind, eye roll. If I had $1 for every time someone told me no margin, no mission, I would donate a large sum of that money to all the causes we're talking about.
And I would celebrate you as an individual doing so. Just don't ask our hospital to do it.
Dave, the cavalry is not coming. There are people in our community that have incredibly real needs which are undermining their health, their well-being, their lives. We work at a very wealthy and powerful institution. We have to use that power for something. What would it say about us as people, as professionals, to know so intimately about them and do nothing? I'm not saying that we have to or should solve poverty. That is beyond us. But inaction is morally indefensible.
You are right. Someone should act. I'd suggest one of the many local service organizations. It shouldn't be us. To paraphrase the great Dr. Bones of Star Trek, damn it, Jim, I'm a doctor, not a social worker.
Oh, man. First of all, I don't really know that. That is so old, like not in my generation. Massive eye roll, please get with the times. The organizations do not have the capacity to do what needs to be done, and we all know it.
If that is true, it's a public policy problem, and it's not a healthcare delivery one.
As someone who lives in this community, we cannot afford to take that view.
Well, as someone who works in this institution, we cannot afford to take your view.
Someone should call the academy. Thank you both so much. So just show of hands, who has ever been part of a discussion like that? Yeah, some version, good. Well, that means that I'm imagining the right things going on. So the question now turns to, so who's right? Because I've tried to make fairly strong cases on both sides because I frankly think both sides have some legitimacy. What I'm going to try and transition to now is to say I think both of them are right under different unstated assumptions. And I'm going to try and unpack what that the key unstated assumption is. In an ideal world, I'm Team Abrams, meaning I'm Team Eric. In the world we live in, corrupt and fallen in a theological sense, and deeply challenged, in which many people do not live up to the demands of justice that, John Rawls and other political philosophers would lay out, I'm personally Team Jackson. And I think the key line that I put in there that Diogo delivered so beautifully is, cavalry's not coming. It wasn't coming on January 19th. I certainly don't think it's coming now. And so while I'm very willing, and I have already kind of publicly acquiesced to the fact that under ideal circumstances, I would not, for the most part, lay this at the feet of healthcare delivery organizations. I think under non-ideal circumstances, particularly for the institutions that I've been at, that have fairly deep pockets, no matter what they say, I am really committed to the idea that inaction is morally inexcusable. So let me give you just a touch of political philosophy here so that you all may go out and feel perhaps extra wind in your sails in making a similar argument if you agree. Political philosophy gives us two kind of phrases or modes of theorizing, ideal theory and non-ideal theory. And the key distinction between them are the assumptions you make about the background conditions under which you're forming some plan of action. Ideal theory really focuses us on the world as it ought to be and the rules that govern the world. So if you all were ever in a college class reading John Rawls, you were reading ideal political philosophy, where we sit back and we say, what are the obligations of people that we would enunciate from behind the veil of ignorance, as if we didn't know what our circumstances would be in this life. And most importantly, it assumes that people, once you enunciate those rules about how people should behave in the name of justice, it assumes that people, hypothetically, comply with those rules. So it really is good at helping identify end goals, but the risk is some find it too idealistic to be useful in the near term for figuring out okay, but I'm a healthcare delivery organization and I gotta figure out whether I zig or zag in the next quarter. Non-ideal theory, on the other hand, takes the world as it is and people as they are, and that is partially compliant, sometimes barely partially compliant to rules and obligations. So this means people don't generally fully pay their taxes. We all sort of say ooh, how could I find a little bit of savings here and there? People don't generally act particularly benevolently towards their neighbors. We say oh, I don't know, my kid could use those new Jordans, and so I'm gonna put that money to them rather than local food pantry, local food bank. I myself am 100% in the partially compliant camp. This is not me saying that I am and others are not. And thinking through non-ideal theory generally helps create pragmatic solutions. That said, the critique of when you do non-ideal theory is some people will say you've dumbed it down too much. If we're all just kind of crafting solutions for a non-ideal world, there's no off-ramp to something better. We'll just stay in the non-ideal forever, and we never reach sort of escape velocity to actually change the world to be more ideal. And so when I sort of set out this little skit, and I hope you guys can recognize these two people in your own home institutions, Abrams, that would be Eric, is an ideal theorist. He's saying we should not do this. It's other people's job. It's a public policy problem. Those are kind of the resounding sentiments of people who are assuming ideal conditions and not just mistakenly assuming them, but sometimes think it's important to be clear about what the ideal state is and what our role in it would be. And he, and I think many others, favor a tight conception of role boundaries assuming that there are social service organizations or there are public policies that can do what we call health-related social needs, that other people would just call social service or social supports, more effectively, more cheaply, more efficiently. Diogo was playing the role in the skit for me as a non-ideal theorist. That's where she says, the cavalry is not coming. We cannot turn our back. There's too much moral urgency. At one point, she even said, look, Eric, Dr. Abrams, I would agree with you, but, and when you hear those kind of sort of phrasings, you generally know, oh, that's someone who's working under a set of assumptions that the world is non-ideal and is not changing in the near term, and we need to respond to the non-idealness as it confronts us. And I think this is worth just pausing for a moment, because as a chaplain, part of me just really hates like aggressive forms of disagreement, which I think this often takes on in healthcare organizations, that there becomes like team health-related social needs, and there becomes team sort of like doubter or detractor or pessimist. And I think it's important to call out that the non-idealists are not naive, meaning they're not saying like generally, oh yeah, I think healthcare should do this for everyone, all the time, everywhere, forever. And the idealists are not necessarily cruel. They're not just saying like, oh, I don't think people deserve this as a matter of a human right. They're usually saying something a little more nuanced, like, as Eric did, people may very well deserve it, but I just don't think it's our place to give it. And that's, I think, an important difference. Nevertheless, you could say like, okay, Lauren, so now you've just kind of deepened the complexity, but still the impasse remains. As an operator, should we act as if the world is ideal or non-ideal? And this is where I think it's important to think dynamically, or think longitudinally, we would say in research. And the next couple slides come from a forthcoming paper that I just need to recognize is co-authored with Kelsey Berry, where we sort of take from political philosophy this idea that thinking in non-ideal terms, or what the philosophers would call non-ideal theorizing, is transitional in nature. Meaning, in the near term, performance should be judged against non-ideal conditions, but in the longer term, performance should be judged against ideal conditions. And we should, as managers, be able to hold both of those in our brain and actually be charting a path of action that is both responsive to the world as it is, corrupt and fallen and sometimes politically cruel and in great need of care and resources and attention, and think about how our action in the near term moves us to a place where ideally the world would be fairer, more just, more kind, more caring. And so the metaphor I would offer is of bifocals. And so I think if a manager came to me and said, so Lauren, like, what do? I would say, like, talk to your team about their ability to wear bifocals in a metaphorical sense. Bifocals, as everyone in this room probably knows, allow you to both, out of one part of the lens, see things that are near, and then as you lift your gaze, you're able to see clearly things that are far. And I think in relation to doing health-related social needs, or really more generally thinking about tough calls for health systems, where they're thinking about their role boundaries, you need to have a certain gaze as a manager about how are we going to respond to the non-idealness of the world, and simultaneously be able to have a thought about how we would respond to a more ideal set of conditions. And being able to talk about both, I think brings both Team Abrams and Team Jacobs into the fold in a way that's healthy for kind of senior teams and leadership teams, but also I think just gives more sort of a principalism to the way that we craft a lot of these health equity strategies. So I wanted to just say one thing about, there's a risk that when someone says like, oh, well, the world's not ideal, so we should X, that to claim the world is not ideal gives carte blanche for like any kind of behavior. You know, I could say like, well, the world is non-ideal, so I should be able to just go out and stuff the ballot boxes so that, politicians that I don't like don't win again. But actually political philosophy is fairly clear about like what the requirements of action are in a non-ideal world. The thing you do now needs to be morally permissible, meaning not kind of way outside the bounds of how we would think about what a health system ought to or ought not to do. It needs to be politically possible, so don't spend your energy trying to do something that will never actually take effect. And then it needs to be likely effective, where effectiveness is saying, like, does it put our organization in a position to reach whatever that ultimate goal is that we have in ideal theory? So if Eric was saying, like, look, in the ideal world, we would do just medical care. And if we want to take that as sort of a working assumption here, we would say, okay, so what can we do in the near term that's morally permissible, politically possible, and puts us in a position that in the long term, we can say, Eric, fair. We're on a glide path to try and get there. But in the near term, we're going to take some additional action that you may not like. It's going to feel worse before better for you. But those are important criteria so that we aren't just sort of relaxing the idea, oh, non-ideal conditions, anything goes. Anything does not go, there are still constraints. So let me just say a word about how I think this would apply quite practically to a healthcare delivery organization that, for instance, is interested in food and decides that it is going to build an on-site food pantry, just as a, for instance, a simple case example. I think the implication of this for managers is you have to think about defining success dynamically. Again, that where dynamically is being used as a synonym for longitudinally. So I just kind of sketched this out for discussion purposes. The numbers are not tremendously important. But let's think about a food pantry or a health system where they're screening a set of patients, then they're referring a set of patients to the on-site food pantry, and then the third column is actually how many patients are receiving food services on-site at our such and such a hospital food pantry. And T1, T2, T3 are just different points in time. You can imagine in sort of a classic business school performance management class, this is like phenomenal success, right? Because the numbers in the third column are going up. 50 is more than 18 is more than 8, et cetera. And this is like monotonic growth, right? It's what all the tech firms would be excited about, hockey stick growth. And the non-idealist would generally look at this kind of trend line and say, like, this is a win. A lot of people who would otherwise not receive food are receiving food, which is a basic human right. And so we are ahead of the game on net by virtue of our system or organization's engagement. And the idealists would say, like, this is a total loss. Health systems get to determine who's deserving of food. Their view of who's legitimate or deserving is too narrow compared to what would happen if other food-focused organizations were taking the lead. And I would just note that, like, here, recognize the fact that the counterfactuals are different. The non-idealist is assuming if we didn't do it, no one would do it. So we're ahead of the game. The idealist is saying if we didn't do it, social service organizations would do it, so we're potentially behind the game. And that's how two otherwise reasonable people can come to dramatically different conclusions about the rightness or wrongness of this kind of program. And the compared to is often unstated. I just want to emphasize that again, so the more we can bring the what's your counterfactual into the scope of discussion, I think the further we are down the path of being able to discuss, well, what is the reasonable counterfactual? What makes you think if we stopped doing this, a social service organization would do it? Or what makes you think if we didn't do this, that no one would do it? And those kind of counterfactuals can actually be investigated. What I would say, and I wish I had better animation on this slide, is that going back to the idea of thinking dynamically, I think most health systems, as I said, probably have a role in the near term, responding to non-ideal conditions, engaging. And it's a fuzzy term that I'm using intentionally. That engagement could mean direct financing, direct service, direct partnering, a bunch of different things that we could have a more nuanced discussion about. But there is a point where I think we have to know that we have an intention to shift strategies to respond to what is hopefully a more ideal world coming into view. And that means that in the near term, we not only need to be doing the work of sort of meeting the urgent need, that is food or utility assistance or et cetera, but really thinking about holistically, how do we try and bring a world into view that's more ideal? That could mean, how do we try and bring a world into view where policies are more fair? How do we try and bring a world into view where communities have more agency? How do we try and bring a world into view where social service organizations are not quite as precarious as they are now? That's the work that really will allow us to eventually step back and sort of take on the role that Dr. Abrams wants us to take on and the idealists want to take on, where we could potentially contract. So what you see here is this idea where the green sort of line that looks like a normal curve would be sort of degree or the intensity of health system engagement in any one health-related social need. And the blue line is sort of the intensity of engagement from social service organizations, or maybe even from policy. And I put it up there just again to hopefully leave you with a sense that we can be sort of nearsighted, like we got to make a decision now and we got to just zig or zag, but actually sort of a longer term horizon can again bring potentially really conflicting forces into view and into a sense of sort of order and right relationship. I just want to call out one managerial insight, which is that I think the decision to shift gears between a near-term strategy that responds to non-idealness and a long-term strategy that responds to more idealness is really tough and is a judgment-laden decision, and I offer no valuable help. But like, man, is that what I think really good leadership should be thinking about and focused on. Like, it's that question of what are we looking at measure-wise? What are we looking at data-wise to figure out when we want to start to pull our foot off the gas or sort of titrate our approach? This is not a set it and forget it kind of thing. I think if you take what I'm saying at face value, it's something where you engage, you respond to the moral urgency, but then you're watching numbers and metrics and you're having conversations, kind of collecting qualitative data on a quarterly, if not closer basis to try and figure out, okay, what have we successfully done to try and bring those more ideal conditions into creation? And what can we start to kind of share the burden of or offload with other organizations, other policymakers, et cetera, so that we are sort of on that glide path to diminish our role. I said a little bit on this before, but I just want to reiterate, I think part of the value of thinking about the engagement of health-related social needs through this lens is that it changes the relevant questions among senior teams from a one and done, should we zig or zag once and for all, which can lead, I think, to these kind of ad hominem attacks like, oh, if Caroline's not in, she must be cruel and unfamiliar with the world. And she would say all sorts of similar ad hominem attacks about me. Those emerge when we put like really stark binaries to people. But if you, again, sort of take this at face value, what it does is open up a set of questions that are more nuanced, and I think we can actually bring more empirical data to. What should we be aiming for in the long term? What should we do in the near term? What's our transition plan from how we'll shift from one to the other? And then the really tough one, when should we begin to shift our strategies? What will we see in the data that makes us feel like, okay, we can sort of start to lift our gaze from that near-term portion of the lens into the longer-term portion of the lens. So I'm just going to summarize here, and then we'll have about 10 minutes for Q&A. The question that was put to me is, whose job is it anyway? And I think my three sort of takeaways would be, one, analyses of what a health system or a clinic is ethically required to do are strongly influenced by assumptions of ideal or non-ideal conditions. And that if you can manage to excavate those from discussions that are heated in boardrooms or break rooms, you tend to find more convergence, if not full agreement, convergence which is valuable from sort of an organizational and team dynamics perspective. My own view, and you don't have to agree with this, but what I've tried to convince you of is that non-ideal assumptions are appropriate in the near term, making healthcare's engagement in health-related social needs at least morally permissible, if not morally required. And I think whether it's morally permissible or morally required has a lot to do with sort of the resources in any given healthcare organization and the kind of strength or precarity of the surrounding social service, safety net, and policies. And then, sorry, that's my third point. The appropriate scope of engagement is likely determined by those two factors. That's both determinative of the scope and where you fall on permissible to required. All right, with that, I'm going to say thanks. I've thrown a lot at you, including a little political philosophy, which may not be what you came to SIREN for. But I feel like a doctor who sneaks in vegetables in the smoothie. So with that, I'm happy to take questions, and there is a mic in the middle of the room. I'm also just here to take fervent praise for Erica and Diogo's performance. Thank you.
Hi, good morning. I'm Justin Adora. I'm here at UC San Diego. I'm part of one of the SIREN grants. Thank you so much, Dr. Taylor. Obviously, the divinity degree is coming through, and that, the ethics and the hard thinking that is required, I think, is super important. But if we ask the question, do we all want the ideal world? I think we all do, regardless of where we are politically, regardless of where we are socioeconomically. Well, maybe not on the higher end, that 1%. But in the end, I think we do. The interesting dynamic that we find ourselves in right now is that in the US, our democracy worked. And now we have Trump again. And we have all the people that are behind him. So, that administration doesn't support dialogue. It doesn't support consensus. All of the things you're talking about, that the solution, at least my takeaway was the solution is the dialogue between the ideal and the non-ideal. Those two folks coming together and talking. So in this reality that we're in, what can we actually do? I mean, the work's going to happen at the lower level, but politically, the shock and awe that we've been through in the last week, for example, is going to continue, and those of us who are on the ground obviously want to keep energized as much as we can. So your thoughts on that and that reality? Thank you.
Thank you for that question. It's an excellent question. I don't know that I have anything particularly profound to say. I think I agree generally with the characterization that there are political forces that are not interested in reaching convergence, consensus, fostering a lot of open dialogue. But as you said, I think that's why the energy and the activity is going to happen at the local level and inside organizations. I said earlier that these are mostly private organizations. There are things about this that are not great. They can act with impunity, and we can all sit around saying, who elected them? There are things about them in this moment that may be great. Now, many of our organizations are heavily reliant on federal funding, and so that's a challenge that we're all weathering. But the actual decision-making does happen by a senior team in a boardroom, in a hospital somewhere. It's not necessarily happening in DC or Albany, and where I come from. And so I think that may oddly work to our advantage in this moment. I don't know that I have that much more profound to say on it other than that. I'm sort of taking this in all with the rest of you, and I'm happy to keep talking about it with anyone who wants to chat over a chocolate croissant. And maybe some brighter ideas will come to me, but it's a fair question, and I think that's the best I can do.
Hi, my name's Katie Coleman. I will be thinking about this talk for a long time, and really appreciate it, so thank you. I'm wondering if you could reflect on that last point on your slide. So if we in this room, I'm guessing many of us would agree that we are in non-ideal conditions and the moral imperative for doing something about social health is here. That's why we've made our career, at least in some point, doing this work. And your comment about the need to transition at some point, or the desire to transition at some point, to do more than spend a lot of time and money thinking about, how do we set up closed loop referrals, and a lot of time and effort thinking about, like, how do we get universal social needs screening and do that efficiently? Like, how do you square the significant implementation costs, the amount of learning, the amount of investment that's required to make that non-ideal moment work against our need to keep our eye focused on this ideal scenario? Because we can't really pull our punches, right? We want to do our best now, and that requires a lot of work, a lot of effort, and a lot of money. And I wonder if you could just explore that a little bit further.
Yeah, thanks, Katie. I think there's a real misperception that if I, as a supporter of engagement of health-related social needs, admit or acknowledge that in the long term, this is not what I would necessarily choose for our health system to be doing, that's pulling a punch, and that will cede ground to the critics inside my organization or elsewhere. When actually, I think that's not right, as long as you have critics who are sort of negotiating in good faith, which goes back to the first comment. But if you think your colleagues are in good faith kind of mounting an argument that we shouldn't do this, then I think actually saying, look, long term, I may agree with you, brings them in rather than gives them ground to kind of trump you in the end-all be-all calculus of whether or not to engage. And so I would just say, I think the idea that it's pulling a punch, it may actually work the opposite way, where you have more power because you've now sort of communicated that you are a reasonable person too, and you have more shared substrate with your colleagues than you think. The other thing I would just call out, though, is that, there's a couple ways in which to respond to this talk that would be to say, Lauren, that was lovely, but I think you're just pretty wrong. And I want to put those on the table because I think I would be interested to hear from you all if you feel this way, and or we can find ourselves out there, and I'd love to overhear conversations that follow. One is to say, Lauren, and I think if Rishi's here, I think I might attribute, hi, my friend, that this might be a Rishiism, but I think someone thoughtful and smart might say, Lauren, I think you're just wrong on your articulation of the ideal condition solution. You've said the ideal condition solution is for healthcare to go back, stick to its knitting, do medical care, and let social service organizations and social policy handle what we now call HRSN. That's not the ideal condition. The ideal condition is going back to an old school sense of Jack Geiger community health centers, where things were very deeply blended and braided, and there was virtually no distinction between health and social services. And that's the ideal. So that would mean keeping all this stuff very long term and deeply knitting it into the fabric of what it means to do healthcare delivery at a local level. And I think that's a really interesting thing to chew on. The only thing I'd say in response is the good news is whether you hold that view, which I'll attribute to Rishi, and he can tell me after it's not true, whether you hold the Rishi view of the ideal conditions or the Lauren view of the ideal conditions doesn't terribly matter for what we do in the near term, because either way in the near term, we're sort of taking on some of this activity and responsibility. But do I think it's a really good discussion to have over lunch? 100%. And part of it is probably all of this is sort of bounded by what we think is politically possible. And sort of now it's really hard to think very clearly about what we think is politically possible, but that's intimately bound up in which of those ideal scenarios we want to latch onto and start to craft strategy towards. Alternatively, I think another way to say, Lauren, you're just wrong. Some people would say, Lauren, you're just wrong in that the way to coax more ideal behavior out of other people, other organizations, policymakers, is not to change your behavior. It's to hold the line. You act as if things are ideal, and it will force other people to sort of rise to the occasion and act as if things are ideal. I don't buy that empirically, because I think lots of times we have tried that. Like, this is similar to how lots of people think about welfare policy. Well, if you just don't give people stuff, like, they'll figure it out, and they won't need stuff anymore. And it just empirically seems to not bear out, but I think that's another line of attack to what I've said is like, Lauren, I hear you on non-ideal, ideal. I just think your attribution to non-ideal conditions that we need to change our behavior and kind of respond to them uniquely is incorrect. Instead, we should just hold the line. There may be others as well, but I just wanted to put those out there to, again, foment. It's always good for some people to leave a little disgruntled and like, I think she's full of it. And I very much support that. So that would be at least 2 lines of thought with which you could walk out of here and say she's full of it. Question.
Hello, my name is Alex Schulte. I am a health policy PhD candidate at UC Berkeley in the organizations and management track. My dissertation is about the role of Catholic hospitals in the American healthcare system. So of course I'm extremely interested in your talk and in your work broadly. My question for you is broad in kind of thinking, or I'm curious about how you think about religiously affiliated hospitals and systems and how that kind of intersects with the core tenets of the arguments you put forth in this talk. Does religious affiliation of the hospital matter? Yes or no, and why?
Thanks, Alex. No, thank you. Yeah, I think about religious hospitals a lot, not necessarily in relation directly to health-related social needs, but in relation to their capacity and the justice of their organizational conscientious objections, which is a little off topic, but I'll give you something in response to the question. You can come back at me or we can find ourselves later. I tend to think organizations are just this really overlooked level of analysis in US health policy. We have thought a lot about individuals, individual providers, and we've thought a lot about sort of states and other policy levels. And to me, especially around the conscientious objection stuff, organizations are really different. Individuals, for whatever it's worth, I support their desire to conscientiously object because, again, the hidden unstated assumption around all of the sort of policy support for that has been that if I go to Caroline or Dr. Fitchenberg and she won't treat me, I can go to Dr. Manchanda or I can go to Dr. Sandel. And at the policy level, we've sort of, maybe not those of us in this room, but many people have sort of said, well, states can make their own choices about what's going to be available and not available. And that has been acceptable because we've had democratic means of sort of electing the people whose judgment influences the availability at the state level. Again, the organizational level is especially complicated because you come back to this question, who the heck elected them? So when you have religiously affiliated hospitals that have care restrictions based on some kind of theological or religious commitment, maybe that would be okay if we thought there was really robust sort of marketplace competition all over the United States, where I could go to a Catholic hospital, either know or be told that they don't provide such and such a service, tubal ligation, withdrawal of nutrition at end of life, abortion, and I could say like, oh, thank you very much, I'll go across town. Where I think this gets really thorny is the number of religious hospital monopolies we have. Because there, you're really stuck between a rock and a hard place. You don't have the choice that we assume has historically been there at the individual provider level, where I can just say, no problem, you conscientiously object, I'll go elsewhere. And I don't have the kind of democratic lines of accountability that I would have to state policymakers. So coming to the sort of non-ideal, ideal stuff, in an ideal sort of market circumstance, right, where we had lots of competing healthcare organizations and information was perfectly transparent, there were no asymmetries, et cetera. If you want to imagine that ideal market circumstance, my view might be like, I'm good with organizational conscientious objections. And yet in the non-ideal scenario where I know that many places there is no choice, a religiously affiliated hospital that has care restrictions, has monopoly power, I do change my view. And I start to feel much more critical of those org level conscientious objections, or at least feel that we need policy to kind of offset the restrictions and access that may come by way of them. I hope that was helpful.
Yeah, thank you for writing the paper on monopolies with Sam Dornberg.
Yeah.
Because now I just cite that paper instead of I was laying it all out.
You write things and you wonder, does anyone ever read them? So thank you, Alex. Do you want me to do one more? Yeah. Oh, come on, give the people what they want, Carolyn. No. Yes.
Hi, my name is Iman Hassan. I'm from Montefiore. Thank you so much for this really powerful talk. My question touches a little bit on what others have questioned, but I actually wanted to ask you about the assumption in your presentation that we will reach the ideal world.
Say that one more time.
I wanted to ask you about the assumption in your presentation that we will reach the ideal world. So I too have hope, but I feel that from what I've seen, that beautiful diagram that you had of the smooth lines that go up to idealness has not
That's
been
an
the
academic's prerogative.
experience that I've had. It's been, the lines are very jagged and they go backwards. And they really don't go in that nice smooth way that you illustrated. And so my question is, for people who feel like we can't take our eyes off the bifocals, we can't lift up our gaze to even imagine that ideal world, how do you keep the hope alive that we will reach the ideal world wherever that ideal is?
Caroline, we should have absolutely wrapped this after the last question. Thank you very much. Yeah, man, that's like a movements question. That's a div school question much more than it is a policy question. But for me, though I know it's really tough to find mental space or bandwidth to lift the gaze, lifting the gaze every so often to check in with myself about, does what I'm doing now conceptually put us on that path, is what kind of sustains me and makes me feel like the work I'm doing has integrity. Because if it's not, then we're just kind of in a whack-a-mole scenario, and I feel like there's no hope of exiting the non-ideal. It's because I've recognized the potential to get there that I feel like, okay, the work that I'm doing is not just like working hard, but it's working smart. The last thing I would say is that it's not at all that I think we will definitely get there. It's not at all that I think we will definitely get there, you know, to quote Dr. King, in my lifetime. But there's value in the striving, and there's value in the doing, and there's value in setting that course. We may not see it done, our children may not see it done, and yet, as I said, I think knowing that we have thought that through and backed ourselves into this course of action is what sustains us, and again, gives the work its integrity. So thank you for the question, and thank you all. I'll see you over chocolate croissants outside.